Hi and welcome to another episode of the Physio Pod. In this episode, my guest is Christopher Boyer from the US, and we're going to talk about the subject of working in an environment within the military and the general thoughts about working with very active people. And Chris is an expert in that. Because the reason why I've invited you, Chris, is that there seems like to be a huge physical and mental demands, and within the army and also in general within very active people, but and medically people being medically discharged seems to be quite a large burden because it costs a lot of money. And within the army, it's my assumption, maybe you can clarify that later on, that a huge amount of money is spent on the individual, of course, due to a larger perspective than the individual. So I was very interested in hearing people working for that realm on how they're doing and what their experience is. So, Chris, I gave you quite a lousy introduction. So could you please introduce yourself a bit more to the listener?
Sure. Thanks, Brian. My name is Chris Boyer, and I'm currently an active duty United States Army physical therapist, and I am stationed overseas in Vicenza, Italy, with the 173rd Airborne. I've been a physical therapist now for 7 years. I have a board certification in orthopedic physical therapy from the American Board of Physical Therapy Specialties, and I also have a diploma in mechanical diagnosis and therapy. I do have a disclaimer to read that the views and opinions that I'm presenting are mine and do not represent the views of the United States Department of Defense or the United States Army. And appearance of or reference to any commercial products or services does not constitute Department of Defense or Army endorsement of those products and services. And the appearance of any external hyperlinks in the show notes does not constitute Department of Defense or Army endorsement of the linked websites or the information products services therein. So big disclaimer, it's just part of our social media policy. But before I was a physiotherapist, I also was in the Army as a combat soldier, first an infantryman in the reserves, and then a cavalryman, where I deployed as a platoon leader. And then I changed my career. So just happy to be joining you today, Brian.
Well, thank you for that presentation. And it's like the disclaimer just reminded me that you and I actually have a common disclaimer that we're both quite biased because we have the same educational background.
That's right.
And we both trained in Austin, just with like 10 years or a bit more abroad. So I must be way older than you, Chris.
Not that much older, but but yeah, we do have that commonality of MDT, and again, like my discussions of MDT are related to just my personal experiences, and I do volunteer as a faculty member for the International Diploma online for 1 week a year, and I am a probationary faculty member with Mackenzie Institute USA. So there's that. So I am biased, but again, everything I'm presenting is from my personal perspective and not beholden to any larger organization, whether that's the Army from my official professional life or the Mackenzie Institute from the work that I do in my personal time.
Yeah, thanks. Chris, you kind of caught my attention because it sounds like it's a long time ago, but back in 24, you actually wrote an article, The
Did.
Musculoskeletal Imperative, Enhancing Combat Capability for Effective Injury Management. And that kind of reminded me of a client I had some years ago who were in the special forces in at the Australian Army, and he told me that in that realm there was like about 40% who was like medically discharged, and it just sounded like a very like massive number to me. So that's why I thought, okay, this guy's written this article, and let's hear if he can like expand on how it is to work in that world. Um,
Yeah, absolutely. Well, I mean, military is very physical, but military is also it's not that different from, the normal population. We see that worldwide musculoskeletal diseases are a major healthcare spend. And they're a major thing that we are working on as a profession in physiotherapy to really kind of deal with this problem set. And the military, we do have a fair amount of people that are medically discharged because of musculoskeletal issues. I don't know the number off the top of my head. A bit different from the Australian number. I don't think it's 40%. It's much lower, but musculoskeletal issues do play into 80 to 90% of all of our medical discharges. So whatever the primary reason is, there maybe are secondary other reasons why someone is medically deemed unfit, and musculoskeletal is always part of the mix. So we have a lot of emphasis on how we do what's called injury control. And there's been a lot of really great research done by people such as Dan Rohn, General Deidre Tahan, Joseph Malloy, really looking at, how do we quantify this problem, because it's a massive problem, and then can we even do primary prevention? Can we look for risk factors, that sort of thing? Just how do we really get after this problem set? It's such a problem that over 10 years ago, I want to say it was probably about 2010, the Army completely redid, the United States Army completely redid its training manual for physical training because too many recruits were getting injured from just physical training in their basic training. So they came up with a brand new way of doing physical training, which helped the injury rate to some extent, but it still didn't create enough of a dent in the problem. So as an Army, we've now moved forward into a second major kind of change in how we do physical training called holistic health and fitness. And our new doctrine integrates not just physical training principles from exercise science, but also how to sleep and nutrition and spiritual health and cognitive well-being. How does that all fit within it? And to that end, we are now sending teams of professionals to large Army units. So about 5,000 soldiers will now get a team of about a dozen individuals, to include 2 physios, 2 occupational therapists, a lot of strength coaches, some athletic trainers. The mix kind of depends on the location. But it's this problem, and it's a bit of a wicked problem, right? When we think about military medicine, there's a lot of, your mind immediately goes to the trauma, because that's the bad stuff. That's the stuff that we see on the news. That's the stuff that's scary. And over the global war on terror era, the United States military really revitalized military medicine and trauma. Before 2018, maybe 2015, how usual was it for you to see regular civilian paramedics carrying tourniquets for blood loss, to stop blood loss? In the United States, wasn't that common. But a lot of these lessons learned on the battlefield then informed medicine. So we have a completely new suite of education for our medics, and they do they do incredible things. They put on tourniquets. They could do crikes to open up an airway. They could do chest tubes. We teach adolescents how to do this very complicated work that is only done by qualified paramedics and surgeons not in wartime. But we still can't figure out musculoskeletal. So it's like, well, what on earth are we going to do here? And my article was really just making an argument that this is a problem. It's not going anywhere. Just because we anticipate that war is going to get bloodier and nastier, as it often does, it doesn't mean that we're going to not have musculoskeletal injuries. I found a volume, actually, Brian, of it was a medical statistics, a book that was scanned onto the internet from World War II. And there were plenty of musculoskeletal injuries that happened to Americans in World War II as well, from sports or, falling down or anything, right? But we don't talk about that, because it wasn't a major point of emphasis.
Yeah.
But now, now that we've kind of solved some of the bigger issues with things like antibiotics and vaccines, well, now musculoskeletal is a big issue. So the number one reason that people were evacuated from Iraq or Afghanistan, if they weren't war wounded, if they weren't shot, if they didn't take shrapnel, but they still needed to be evacuated, they were evacuated because of low back pain.
So
That's ridiculous. So again, like it's this big problem, and I get very fired up about it because I think about it like it's staring us right in the face, and we need to do something about it. And there are a lot of people trying very, very hard to do things about it. I felt that I would provide my perspective on it, and I'm glad that you found the article.
yeah.
But I'm hopeful that it could start a broader conversation in the Army.
Yeah. So has it started like not just your article, but do you think there's a turnaround in having a more focus on the MSK area?
I think so with the new holistic health and fitness
Yeah.
initiative. It really puts an institutional emphasis on, and not just musculoskeletal. I mean, it includes nutritional health. So we're looking at body composition and mental health, especially. So thankfully, it's not just MSK. It's everything, but it's certainly the hot topic now, right?
Yeah.
Is this holistic health and fitness called H2F? So it makes it easier to have these conversations and because it's more in the forefront of our broader conversation about soldier health.
Yeah. So to me, like the holistic healthcare, was that where you no, you turned
Yeah. Well,
yeah.
it's that's what we call it, holistic health and fitness.
Yeah. So to me, that's like a broad umbrella. Within that
Yeah.
umbrella is the is there like certain things you have to do when you're working there as a physio, or is it like in the real world where people seeing those working in healthcare that sees MSK patient, if you could say that, I know it's a bit narrow calling people MSK when it's a human being, but that they are seen by a wide perspective of clinicians, like from Quakery to physiotherapists, osteopaths, and I mean, it's very different what they meet. Are you having some kind of standard that you need to meet your people in within the army?
Yeah, so we keep it really kind of channeled into credential disciplines. So we use physical therapy, occupational therapy, dietetics, behavioral health professionals.
Can you say the last one again, Chris?
Sports injuries and the diagnosis and treatment of injuries, but also working through a performance aspect. So if I have a group of individuals and we need to get better at a particular physical domain, for example, their aerobic fitness needs to be better. Then even though I do have strength and conditioning coaches, I'm still in charge of that aspect. So I put my performance hat on and I act almost like a team physician or a team strength and conditioning coordinator and start to gather information and direct the team to then influence the exercise plans of the clients that we're working with. So it's really cool because it's definitely some clinic work and a lot of very standard physical therapy stuff. But then it blends a little bit into the strength and conditioning realm. And thankfully, I don't have to be an expert on that because I have coaches, but I get to, at least from my background, take a look at the problem and say, here's where I think the coaches need to be working, and here's where I think we need to maybe do some screening. We need to do some kind of understanding of if these people are healthy or not, from my standpoint, before we can have the coaches work with them.
Yeah, yeah. But it's not like you and I have a mo more or less similar background to some extent. You don't have to have that background. You have to have the authorization of being a physiotherapist. Is
That's
that
right. That's
correctly
it. You
understood?
just have to be a licensed physical therapist in the United States, and
Yeah.
then most of our injury control directors are also board certified in either orthopedics or sports. So that's another thing that we try to get.
Okay. Okay. So that also means they can get quite the soldiers can get like quite different perspective on how they should seek help and which kind of treatment they're given.
Yeah, sometimes it does look like that, depending on the background of the practitioner and personality dependent, right? So some of my colleagues really like to dry needle, and they use a lot of dry needling. I'm trained, I'm fully capable of doing all the dry needling. I just don't see a need for it. So if you come to see me, I'm not going to stick needles in you immediately. Whereas some of my colleagues are a little bit more aggressive that way. So it's almost like seeing just different physios in that respect.
Yeah. Okay. Okay. So working in that realm, what kind of competencies we've touched on some of them, and then what kind of you could add the rest of the team in which what where you think they should go and stuff like that. But are you in the position where you can like order an MRI or do blood tests or stuff like that? Or are you just like I am working as a physio? I can't authorize that and I can't do prescriptions for drugs and stuff. What about
Yeah,
your position?
I could do a lot. So trained since so this actually started in the Vietnam War. In the Vietnam War, the Army had a shortage of orthopedic surgeons, but we had plenty of physical therapists. The
Mhm.
Army always has plenty of physical therapists. So the big Army said, you know what, we're going to let our physical therapists order X-rays and lab tests and some drugs. So when I went to physical therapy school, because I went to the Army program, credentialed through Baylor, I took radiology courses and courses on we called it primary care physical therapy. So lab values, lab tests, non-musculoskeletal, like rheumatological conditions and how they
Yeah.
can manifest. So a passing knowledge on that. And I'm able to do all those things in terms of ordering. So I can order any imaging that I want to order. I can order a handful of drugs, mostly analgesics, NSAIDs, no opioids. Paracetamol, ibuprofen, naproxen. I can lidocaine patches, diclofenac gel. Nothing terrible, but just minor things. And then I can order, really standard lab studies. So the one that I do most often is a serum vitamin D for soldiers with bone stress injuries,
Yeah.
and I could also prescribe vitamin D. So what that turns into in practice, we have the privileges. The lab for example, I've had a couple soldiers with inflammatory arthropathies, and thankfully, I have two internal medicine physicians that are on my team. So I'll usually get in touch with them and say, "Hey, I think this might be rheumatic. You okay if I order some labs and send them back to you?" And that way, it just saves them an encounter and it saves the patient some time.
Yeah.
So I'll do that. We have those, and I wouldn't tell you that I'm as competent as a radiologist or an orthopedic surgeon in looking at X-rays, but I'm pretty good at seeing the big things, and I'm pretty good at reading knee and spine MRIs just from a lot of practice. The reality is that when we go to the field, and I had this experience in the last fall, when we go to the field and we set up our medical treatment tent, it's a big tent. It's really impressive. We actually have a mobile x-ray machine. So we had people that came in and they were training. It was, NATO exercise. They came in and they'd have a swollen ankle and we could x-ray it right then and there in the tent in the middle of the forest. And at that moment, it's between me and a couple physicians in the tent of can any of us see something that looks broken? That's the only radiologist we have is like the combined brain power there. So I take time to self-study it as best I can, and I try to have some competency in it. Uh, Especially since I could order the scans. But it's a point of emphasis in our education and even our continuing military education as military physical therapy providers that, especially when we're getting ready to deploy, that we brush up on those skill sets because we might be the only medical provider in a particular area for a length of time. It's possible. So we want to make sure that we're somewhat useful.
Yeah. Chris, are you aware of any like data or what you've talked about with your fellow colleagues that because it's not your primary thing to do, and because we have radiologists and we have orthopedic surgeons that let's like traditionally do it or are given the right to do it more often. Do you have any data that says that you're doing it too much or you're doing it too little, like prescribing for X-rays, or don't we know anything about that? I'm asking because like it's getting more common that physiotherapists work in GP practices in Denmark. And I don't really think we can say that we have any data that or at least the data we have, it's so small that we shouldn't comment on it. Are you?
Yeah, so there is a an article from Joseph Moore, and it's in JOSPT in 2005. And I believe there was another follow-up either done by I think Tim Flynn was one of the authors, but
Yeah,
they were looking at that exact question, which is, do physical therapists order too much imaging?
yeah.
And the answer was is we actually order the least amount of imaging when you compare us with primary care providers. This, yeah, let me just see real quick. I think Don Goss was another author on this paper from 2005 in JOSPT. And it's called Clinical Diagnostic Accuracy in Magnetic Resonance Imaging of Patients Referred by Physical Therapists, Orthopedic Surgeons, and Non-Orthopedic Providers. And yeah, the conclusion here, I can't believe I just pulled this off of my head because I we talk about this in school actually because
Yeah.
Joseph Moore, the late Joseph Moore, is a retired colonel, awesome guy. Unfortunately, passed away recently, but he did a lot of really amazing research and studies like this one to say like physical therapists belong in this realm and we're a value add. So the conclusion to this study was that the diagnostic accuracy by PTs was significantly greater than that of non-orthopedic physicians. And there was no difference noted between PTs and orthopedic surgeons. So the diagnostic accuracy is very high. And I'm sure if you give me a little bit of time, I could find the study on did we order it too much. I'm really sure that Tim Flynn was an author on it, but I might be wrong. Weimer might have been not Weimer. Weiner might have been an author. A lot of these are all Army Baylor faculty members, you know.
Okay.
So they're like in the military environment and they published on it. But I remember the bottom line is we're accurate when we are adequately trained, and we do not order too much. And primary care they order a lot. I
Yeah.
mean, that's why we have
And
Ottawa rules, right?
yeah, are you using those? I was just thinking about, are you using that within the army? Are you using the Ottawa rule for ankle and knee?
Oh yeah, yeah. I
Yeah.
use Ottawa ankle and knee, Canadian C-spine rules.
Yeah.
Those are the big ones that I use. Ottawa rules. We teach all of our combat medics the Ottawa rules as well, so that they can understand it.
Yeah. Yeah. We teach on the grad students.
It's good.
And actually, I can use it. I wasn't aware of those until some years ago because it wasn't part of my training, and I haven't like kind of met it on my path. But then we started teaching it, and it's a really valuable tool.
Oh yeah, the Wells criteria for deep vein thrombosis. That's another one that we were taught in school. So a lot of the primary care things is a point of emphasis at Army Baylor, and certainly a point of emphasis in military practice because we have direct access. I see a number of patients before they've seen their GP. So I have a detailed screening form, and I go through a fair amount of questions, and when I have to take vital signs and look at different things because I'm in the position where I can be the first person to see something. I've seen a couple gout flare-ups, as I'm the first person to see it. Um, we had a pretty significant surgical complication that my staff found. And thankfully, because we have so many touch points, it's not that the GPs don't care. It's just that physical therapists, I might see these folks 2 to 3 times a week. So when things
Yeah.
start to get weird, I'm able to see it first and then act on it. But it's I'm very grateful for my education. Let me put it that way.
Yeah. It's worth all the money.
Yeah.
I also guess like working within your environment, like demands are quite high. Because like just like active like people, professional sport athletes have like high demands to get back after your injury. You have to get them like ready for service again after an injury. Do you think we can say it's a bit similar to professional sports? That there's always not just the person being injured, but there's also something higher up in the hierarchy or some peers that are kind of wanting them to go fast uh, in the process of getting back to where they were. Do you experience
Yeah,
that as well?
absolutely, Brian. I think that's a really good parallel. So in professional sports, there's obviously the peer pressure, and then there's also the career pressure. If I'm out for too long, I lose my spot on the team, and there's someone who's maybe just as good as me, and if they take my spot, then that's it. Um, Thankfully, no one is going to in the army is going to lose their job and lose their income, but for some of our leaders, if they are hurt for too long, they lose their leadership position. So they might have worked very, very hard to get into a position where they're leading 10 people or 30 people or 200 people. And then if they're hurt for too long, then they are replaced because we have to be ready to go.
Yeah,
Um, and that could be a barrier, right? Because sometimes people are out there walking around hurt and they don't want to come see the doctor or me because they don't want me to say, we actually have to put you on some restrictions for a little while you heal. Um, so so that's a tough one. And thankfully, though, they don't lose their paycheck, right? The athletes, they could lose their paycheck, which
yeah,
is even
yeah.
worse. The other way that it's similar is it's in the when we get them ready for discharge, I think there's always that question of are they as good as they can be? Am I testing them enough? Should they be stronger? What types of functional movements or functional tests can I use to simulate what they're going to do so I could say, yeah, I think you're good to get back out on the pitch. Or in my case, I think you're okay to jump out of an airplane again. And that's difficult, right? Because really the best test is probably the game, but we don't want them to fall apart. So I pull a lot from the athletic literature, and I use a lot of their functional tests. I use the functional capacity screen from the functional movement systems folks. I use the hop test battery. I use a Tyndek dynamometer. I use handheld dynamometers. I try to use whatever I can. Y balance tests to quantify and to think through, but also sometimes my patients will say, "I'm good enough. Uh, I'm fine. Bye bye." And I'm like, "No, wait, come back." And I'll hope that they're good to go. So if they say, "You know what? I'm feeling 90%. I'm ready to do this. I did a few things. I don't need to come back." you know, I, I I can't. I'll give them a little bit of an encouragement to maybe do a little testing first, but if ultimately it's their choice.
Yeah,
But then on the flip side, it's also hard because sometimes, just like with athletes, it's like the first time they've ever gotten hurt and their confidence is shot. And you see them progressing and you see them doing really well. And you kind of want to give them a little pat on the back and say, okay, you're ready to go out there, get back. And they're like, no, I'm not ready yet. But then it's like, well, physically you are, physically you're good. But then it comes back to, well, I still have to jump out of an airplane with all of this gear on. How do you know I'm going to be good? And I say, well, that's an inherently risky thing. I don't know that you're going to be good. And that's the truth. Just like sports are inherently risky, so it's difficult. But it does force you to have some interesting and fruitful conversations with the patients. And you have to really be on top of, I think, your craft in terms of making sure of course, at the front end, making sure your assessment and diagnosis is right. But then really looking at those functional baselines more so than the subjective report to quantify as best as possible, not just for your own understanding, for my understanding, to see have I gotten there? Have I achieved what I wanted to with this exercise? But also to show to the patient through them doing it, like, oh, sometimes that's a confidence boost. They
yeah.
do the triple hop and they're, oh wow, that's actually pretty good. Oh, okay, I'm feeling better, already. Sometimes they have to prove it to themselves, and those tests are a safe way of doing so.
So when you're using some of those measures, I I think I would come to the conclusion that to be able like to trust those measures because some of them because we're individuals, they're not all like validated to some
Yeah.
that need to be able to to put a pressure with that many newtons and stuff like that. So that reminds me, do you have on all the clients you're working with in that unit, do you have like a baseline before they get injured?
I
Like,
don't.
no?
Yeah, it's a good question, Brian. So some people that work with more specialized units, almost
Yeah,
like a sports team, they will collect that data and they do
yeah.
have it, which is perfect. But my client base is 3,000 people. So it would be a little impractical, unfortunately. Now, some though, I like to. I'm knocking on wood right now. To like, it's good luck. I don't have too many repeat clients. I usually get them better, and then that well, they either fire me or I guess they're better.
Yeah.
So sometimes I will have old data on them that I collected myself from a previous injury. But generally speaking, I'm looking for symmetry. I'm looking for at least 90% symmetry, ideally 95%. And that's what I can go off of. If there are published age norms, like for the closed kinetic chain upper extremity stability test, I
Yeah.
can use that. But otherwise, I don't know if it's right, but I go by symmetry as best as possible, and hopefully that's good.
Yeah, 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 because that's just like put a very nice example out of how it is being in clinical practice.
Yeah,
Yeah.
yeah,
So if you're working with somebody with like long-standing pain, like let's say not like that, yeah, it's chronic if it's more than 3 months, but like an ACL, you see patients like that, is it, or at least I assume that based on our conversation, and they sometimes get setbacks and stuff like that. Is there any, do you have any perspective on how you work with that so that people that listens to this podcast can hear what you're doing within your environment?
yeah. I mean, the question is always, uh, I for my post-operative, um, the question comes back to what are we doing in clinic, and are we seeing the results that we want to see? And what is the rate limiting factor? And I think the biggest thing that I'm seeing now with my population is they don't like to slow down, so they get really persistent to fusion. And that I think gets overlooked. So we really have to control that because arthrogenic inhibition is a significant thing, right? Um, but my process is I like to use these objective measures. I really like to use the Melbourne ACL guide, and then we also have post-operative protocols for through the Department of Defense that I use. And if they're not making their goals, then the question is, well, is my rehab wrong? Is the I'm just doing the wrong things? Is my dose or intensity wrong? So maybe they need more frequent, or maybe it's not heavy enough, right? Or there's something else going on. And probably it's because of my McKinsey training, but I always go back for my post-operative cases, and then I try to think about, well, is there also a mechanical syndrome present, like a derangement present, that is now influencing this? And I have seen that multiple times in ACLs and even my, open reduction internal fixation, complex fractures. And I don't know why it generated. Maybe it was their, leaning on the crutches or sitting for too long. But I'll go back and I will look at active range of motion of the lumbar spine, and I will do repeated motions of the lumbar spine. Or for the upper extremity, I'll re-examine the neck, um, and I'll see if there's directional preference there. And oftentimes, I will find that yes, this person also has a MDT derangement syndrome at the relevant spine, in addition to their healing surgery. Or if it's a surgery that I'm kind of, they had it a long time ago and they are, maybe they're coming to me from a different duty station and they were able to complete 80% of their rehabilitation, but it's been really long and they still have this one issue. Then I'll also look at that joint for a derangement syndrome as well. And oftentimes I'll find one, especially with my ankle fractures. I'll find a derangement of the talocrural joint. So I kind of always go through that decision cycle of, am I sure that I got the diagnosis correct? And if I did I match the treatment? And if those things are there, then why is the outcome not there? Perhaps I'm missing an additional piece. And I'll go back and just say, all right, what else could be affecting this entire movement system? is there a derangement that's causing an issue? Uh, okay, maybe not. Is there a motor control issue at a proximal segment? That's another option. But what's the rate limiting factor? And that's how I reason through it. But for me, and for most of my problems, it's I have to tell my clients to slow down a little bit and that they're getting too swollen and that you can't rush Mother Nature. You can only slow her down.
Yeah.
So we need to respect the healing process, right?
You just touched a bit on the MDT now. This do you have some like in which way different than what you just said? Does it like assist you in working in that realm, Chris? Like, does
Yeah,
it? Of course, you're obviously biased.
yeah,
So, but from your perspective, let's take that and let's just ignore what everybody else think.
yeah. I think the biggest thing, if I walk into my job and it's one physical therapist, me, and 3,000 people that are every month jumping out of airplanes, every day running to include this 7 mile hill run to a chapel. They're, doing martial arts. They're doing all sorts of things, all sorts of things. There's one of me. So there are just too many people that have injuries to be seen in a reasonable amount of time by me. So what does that mean? Well, there needs to be more of me. Well, there can't be more of me because there's only one of me, and we can't get more physios. So what do? Well, I have to make people that can do kind of what I do a little bit. And understanding from the literature that derangement is so common, what I used MDT to do was to teach basically the progressions in the treat your own back, knee, ankle, that whole book series to combat medics and to my physical therapy tech. So now, instead of every single injury coming directly to me, it goes to one of them first. And if it's a derangement, well, they fixed it, right? So that was my hypothesis, is that that was good, what was going to happen, and that I would have better access to care. My schedule would open up and have more time to see my soldiers that had fractures and surgeries and very complicated issues. So I just collected my own internal data for a year, and we looked at 160 consecutive patients. And out of 160 consecutive patients, I either had a combat medic or my PT tech, same level of MDT education that I taught them, that got the first look at the patient. 48% of the time, that the tech or the medic was able to fully treat the soldier. The soldier never needed to see me. They had directional preference. It was very easy. They never needed to come back. 48% of the time. So in terms of what that does for my clinic, it frees me up a lot. What that does for these young medics is it empowers them, because a combat medic knows how to save your life. But when we're not at war, what do they have to do? So we teach them some medicine, we teach them some primary care, but ultimately they're in the barracks with their friends and their comrades, and their comrades are coming to them saying, I dislocated my shoulder, help me. And they want to be able to help, but they don't know what to do. So we teach them some trauma. But what happens when it's the chronic pain, or what happens when it's the non-specific pain? Well, they don't know what to do. They're like, I'll throw some ice on it, or I'll look up something on YouTube. So now I've empowered these medics, and they're very excited about it because they see that they're able to do something to help their friends and colleagues. So it's been a tremendous time saver for me. And it's also been great for the soldiers because they're getting taken care of faster. They don't have to wait weeks and weeks to see me. Because not most, but 48% is a pretty big percentage. 48% of everyone coming in has a derangement that can be simply fixed with treat your own back or treat your own shoulder. It's wonderful. That's been the biggest thing. And we, also seeing, and this was actually very interesting, that if you look at all of our isolated extremity pain patients, 75% of them that the medics and the tech saw responded exclusively to spinal repeated motions. So most of so that's the broad the out of everyone that had a derangement, the majority of them were spine, and those that were extremities, were few, but certainly were in the mix as well.
So based on like a very short and quite simple teaching in what you and I would describe as a mechanical evaluation within your population, it actually seems like it provides benefit for both like the tech people and the ordinary, like the more active staff, like the soldiers, right?
Yeah, absolutely. And if you look at like how much time we save, so when someone's injured, we put them on limited duty, and we have data on limited duty. So on average, someone who complains of pain is going to be on limited duty for 90 to 120 days. So I did the math on this a while ago to get ready for a briefing. But 160 people, 48% of them, all of them getting better in 2 weeks instead of 120 days. That ends up equating to about 13 years worth of limited duty that we saved through the calendar year of 2024. So that's pretty significant.
Yeah.
That's if you think about it like a factory, that's time that would have been lost, that like productive time that would have been lost. But in my profession, that means that was time that in some instances, someone was going to have to do double the work because one person was just physically unable to do their share of it.
Yeah. Yeah, that's interesting. Yeah. So you need to collect more data, and then you need to put up a study with a very good method, I guess, and start publishing.
Yeah, perhaps. I don't know. I don't know if that kind of data moves the needle, Brian. I think that was why I wrote my article, and I didn't put it in a scientific journal. Um, in the United States, there's a company that's called IMC, and they're doing MDT, and they're doing it at a high level, and they simply look at the economic outcomes, and they're quite successful in propagating what they need to do because they're just talking economic variables to bill payers. And I thought to myself, well, the evidence base for MDT is pretty good. Um, but for some reason, when I bring that evidence base up, it doesn't necessarily have the impact that I want it to have. So perhaps if I tell a different story, and it's the same story, but just in a different
Yeah.
way to a different audience. And I put it in terms that this audience of commanders, of a war fighting commander understands, then perhaps there's the aha moment. Perhaps I can get that, and we can finally move past the strange tribalism of physiotherapy, scientific discourse,
Yeah.
which it's like any other profession. It's a human endeavor. I don't feel one way or the other about it, but my end state was to affect the army. So I hopefully I can find some additional avenues to tell this story, and I'm glad to have this opportunity to tell the story right now. But I think that the way that this goes further is to demonstrate how powerful it is in the hands of our combat medics, no different than how powerful our new trauma modules are in the hands of our combat medics. I mean, you're telling me that we take a 19-year-old adolescent, a young man, young woman, and we send them to Texas and we teach them this algorithmic structure, and then I can put them on the battlefield and they're going to save people's lives. That is unbelievable. That is like it sounds unbelievable, but it happens, and these medics are so capable and they do incredible things. That is the second largest group of soldiers we have in the army. The first is infantry, the second combat medics. So if I can reach them and we can get this as part of something that they learn, then everyone wins. Soldiers will get faster care. The medics have a new skill set. Commanders have more soldiers that are fit and ready for duty. And we also are teaching an entire generation of people how to treat their own aches and pains, right?
Yeah.
So hopefully we can take this massive problem and start to start to cut down on the easiest parts of it so that we could focus on the hard things, right? Like ACLs, those are hard. Complicated fractures, those are hard. Really significant radiculopathy, that is hard. But a simple knee derangement that responds to extension, I mean, come on, we shouldn't be losing time on that.
Does that does that approach to me it fits with the very active population you're working with because they want to get fast ready. Do you also, or is that just my perspective? Do you think it fits the population?
I think it does because a lot of them are already looking for something that makes them feel better. Athletes like to work out, they like to do their sports. Soldiers like to do what they want to do. So they'll come in and they'll usually show me 4 or 5 things that they've tried on their own, looking at Instagram or YouTube or whatever. So when I show them this, they're first, if it is a journey, they first look at me like I had no idea it could be that simple. It feels like it shouldn't be that simple, but it is very good for this population for sure. I think I agree with you.
Yeah, yeah. Do you have any like because there might be some listeners out there that want to work with this very active population. Do you have like any advice to physios or doctors that want to go into that profession where you are?
Well, it's going to be very different, I guess, depending on where you live, what country you're a citizen of, and if you want to be in the armed forces or not, or how it works. I I don't know. I know that in Canada there are uniformed physios. I'm not really sure how it works and I think in England as well. I'm not really sure how it works in other militaries. But if there's
It
anyone, oh yeah,
Yeah, I think in Denmark, I'm not sure how it works, but there's very few physiotherapists, and I don't know if they're what you would say field active. I really don't know if they are.
yeah.
There's so few of them.
I mean, it's perhaps wanting to work with a similar population like police or firefighters. Um, it's really, can you go ahead and demonstrate the value that you can provide? And a lot of times that just has to do with keeping people on the job and keeping them physically well and fit. And there's an economic cost too. There's how many days that you're paying someone their disability or their work comp, um, and that literature is out there. So I think that that's probably the best thing is to go out and advocate for yourself. But if anyone is listening from the United States, the Army is recruiting physical therapists. So go to your nearest recruiting station, and you can talk to a recruiter about joining and being a physical therapist. But we also have our own physical therapy school, and you can apply without being in the military at all. It's Army Baylor. In fact, many of my classmates had no military experience before starting school. And it's a wonderful program. It's really well done. Um, and there's also opportunities in the United States Navy and Air Force, not to make it a recruiting thing, but I know that this sphere, right, especially for physical therapists and strength and conditioning professionals, is expanding. So the National Strength and Conditioning Association has the Tactical Strength and Conditioning Conference, which I would say is like a really good opportunity for people to maybe network and look to see other professionals in this space. And I know that there are international presenters every year. So definitely check out National Strength and Conditioning Association and the Tactical Strength and Conditioning course and interest group.
Thanks. Um, where can people find more about you, Chris? Are you on social media or do they have to go on PubMed and find your articles if they want to get a bit more of you?
You can find a couple of my articles on PubMed. I have a case series that was written about, I wrote with a couple other military physical therapists about shoulder pain of spinal source. I have another article that's a little bit math oriented and statistics oriented if you want to get into that, but it's not necessarily very interesting. It's kind of dry, but there's also that. And then I am on LinkedIn. I am on X or Twitter at Chris Boyer PT, and I'm also on Instagram at Bonedoc Saints, so Bonedoc Saints, and that is the Instagram account that we have. It's like the official Instagram account for our injury control effort
Ah,
within my unit, so you can see some of the things that we're doing and some of our initiatives there.
well, thanks. That might be valuable. Yeah. Uh, well, thanks for your time, Chris, and thanks for your willingness to participate and share what's going on in your working life within the realm of the military. It's
Oh
been a
no, thanks
real
for the
pleasure.
opportunity, Brian. Yeah, pleasure's all mine. Thanks again.